Copyright Stanford University, all rights reserved.
Good evening. I see some very familiar faces in this room. It's a pleasure to introduce our global health leader for Conversations in Global Health, a entity that we do quarterly. Dr. Chris Elias is president of the Global Development Program at the Bill and Melinda Gates Foundation. I have this also. Well, you can hear me. Can you hear me? Basically, his portfolio, and this is why I have this piece of paper, includes agriculture, family planning, financial services for the poor, maternal, newborn, and child health, polio. Which he just gave us a wonderful talk about, and hopefully, thank you, and hopefully we'll share a little bit more about what's happening with polio, water and sanitation, as well as special initiatives. Prior to the Gates Foundation, Chris was the CEO of PATH. He's been at the Gates for about 3.5 years, but he spent many years at PATH where he really grew that in unprecedented growth for this international nonprofit, really working with innovative health technologies. I also found out that he spent 10 years at the Population Council, living in Southeast Asia and working extensively, some with vaginal microbicides. And lastly, he did very generously serve as one of our advisory board members on CIDEA for the 3 years that we had the NIH grant for innovative drugs and diagnostics in low-resource settings. Dr. Elias holds an MD from Creighton University. He actually did his residency at UCSF. And I heard he was a resident with Susan Desmond-Hellmann. They're residents together. And he has an MPH from the University of Washington. Tonight, he'll be part of our conversation with Paul Costello, our Chief Communications and Public Affairs Officer for Stanford, and a very illustrious interviewer. Paul, take it away.
Thank you. And thanks, everyone, for being here, and thank you, Chris.
Thanks, Paul.
I wanted to start with Ebola. And 10,000 people died during the Ebola epidemic in West Africa, which has largely been abated. Countries that were most hit, there's been not new cases recently, Guinea, Liberia, Sierra Leone. And at a TED Talk last month, Bill Gates said that the world is vastly unprepared for the next epidemic. And an op-ed in the New York Times, perhaps some of you read this week, said, yes, we were warned about Ebola. And it cited a 1982 paper about the possibility of the virus in Liberia. And that it was ignored. And the op-ed concluded, when the history of this epidemic is written, it will chronicle the myriad of ways that from Godot to Monrovia to Geneva to Dallas, we were not prepared. But none of us can, in good conscience, say there was not a warning. So I wanted to ask if you could expand upon warnings, epidemics, threats, and what Bill Gates was trying to tell the global health community about being unprepared and what we need to do to be prepared.
Yeah, there's probably an hour response just in that.
We have a lot of time.
Let me see if I can boil it down to a couple of things. I think one of the things that Bill was trying to say in his TED Talk and in the paper he published in the New England Journal that same week, and in some discussions we've been having internally, is that the Ebola outbreak in the Mono River countries did show us how poorly we were prepared for something we had seen before. There had been about 20 Ebola outbreaks previously. Most of them had been contained to rural areas and had been controlled. And increasingly, the experience with those previous epidemics in places like Eastern Congo and Uganda, South Sudan, is that as people developed more experience with them, they got better at managing them. And several things went wrong in West Africa. It was an area where we had never seen Ebola there before, even though there had been warnings that it was quite possible. There were gaps in our scientific knowledge. There were huge, actually, absence of any meaningful surveillance system that could provide the basis for outbreak alert and response. It was months before it was even recognized that we were dealing with Ebola. And then there were failures of the global health architecture at a variety of levels. So by the time the world kind of woke up to it, it was in urban areas. It had spread further than any previous Ebola outbreak, et cetera. So, we were unprepared. So we need to be better prepared in those particular places. We also saw, even in the U.S., some chinks in our armor here. We thought that our standard infection prevention should contain, and we had some limited number of infections among hospital workers in the U.S., but it didn't turn into a big epidemic. What Bill was trying to talk about in his TED Talk and some of his writings was that actually we need to learn what we can from Ebola. It was a wake-up call. But having now woke up, we need to think about the variety of threats that may face us in the next epidemic. And Ebola in that variety is not the worst thing we're going to face. And if we think about that, one of the things that Bill said in his TED Talk is that if he thinks about what things are likely to kill 10 million people in the next 20 or 30 years, it's unlikely to be a war. It's more likely to be a microbe. And, particularly a severe respiratory, a pandemic influenza like 1918, where, you had an epidemic of influenza that killed more people than both world wars combined. An airborne infection of a high lethality if we weren't prepared for Ebola, we're certainly not prepared for that. And if you think about, the kinds of things that might kill 10 million people, it's more likely to be either an emergent infection, a new virulent airborne strain of influenza or some other virus, or some bioterrorism event. And then if you think about how much we invest in military preparations, including the kinds of reserve personnel that we need for when there is a need for a surge in defense, including the kinds of war games we play to actually think through what would the scenarios be. We don't do that in public health. Another person in the global health world said to me in the midst of this, the newspapers act as though there's some strike force of health workers somewhere. Mm-hmm. There isn't anywhere. I mean, the closest thing we have is the capability that the U.S. CDC has. They deployed over 150 people to West Africa on assignments of several months at a time. That and the voluntary networks that MSF and other international relief organizations have, that's the closest thing we have to a reserve core, if you will.
Is that something that the Gates Foundation would investigate further or put some resources behind? Michelle Berry, in a op-ed, pushed for that, a large foreign core or core of investigators and relief and health work, global health workers. Is that something you're thinking about as you think through how to approach the large issues that we could face?
Yeah, and we're certainly thinking about it. It's not just us, though. I think it's the whole global community. The World Health Assembly, at its executive board in January, had a resolution sort of saying, hey, we should figure this out. Now, how you organize it's an interesting question of, do you build a core? Probably shouldn't be a military core. Is it a network of people in, what was interesting is in September of last year, when it became clear what a crisis Ebola was, many organizations, relief organizations who wanted to help, had difficulty helping because they couldn't get permissions, they couldn't get transport, they couldn't get guarantees on medical evacuation, so that they couldn't they couldn't tell the volunteer doctor who was willing to go to Liberia or Sierra Leone or Guinea that if they got sick, they could get them care either in that country or evacuated for other care. And so if there's not, I mean, people who are willing to go and take risks and who are willing want some reasonable assurance that if they get sick, they're going to be taken care of. And that wasn't in place. So, things like how to prearrange medical evacuation, medical care in country, whatever the right solution is, for people who are willing to be part of that core. And so I don't know that we need one monolithic, new organization. It may be, because in fact, I think most effective organizations these days are highly networked, and it may be that we just get better organized about how we bring those resources to bear. We shouldn't wait, however, until we're in the midst of the crisis to train them. There are a lot of things you can be doing in terms of building the capacity for national response, which is, part of the untold story of Ebola. If you read just the U.S. newspapers, it makes it sound like people from the U.S. and France and Belgium, staffed all those clinics. And certainly there were a lot of people who went and did, but probably 90% of the frontline workers, and certainly reflected in the death of hospital workers, were national doctors, nurses, care providers from those communities. And so building the capacity of, in between outbreaks or in between epidemics, there's a lot of work to be done in terms of preparing the response for, surveillance, outbreak recognition, alert response, building. We were talking about this in the previous session about polio. The tools are important, and we should improve them. We should have better drugs, vaccines, diagnostics, all that. But it's actually the political and management organization that allows you to use those for public health impact.
I was going to ask you about that. How critical and important is it to have that, first of all, the infrastructure, clearly, but the political leadership? What is the value and importance of the political leadership that you've seen in maybe not just in sub-Saharan Africa, but throughout the globe?
I think the political leadership is actually quite important in terms of enabling other people to get to do the technical work, right? So if you've got political leaders who are denying that they have a problem, we saw that back in 2003 in China with SARS, and that recognition of the problem that initial denial led to actually started the momentum for the creation of the international health regulations and a better agreement among member states to be more transparent about data when there are outbreaks. So you need political leadership to enable the technical response in many places, and that's actually, so bad political leadership can completely disable a response if it's denying access or denying transport or making policy choices that may, like shutting down all the commercial flights or something, that may actually make it harder for technical assistance and needed commodities to move across borders.
Will we see, you mentioned that you were in a prior session talking about polio. Will we see, and how soon will we see a sub-Saharan Africa free of polio? And I understand that right now the target areas are northern Nigeria. And what is the problem today? Is it just in Nigeria, northern Nigeria? And how soon do you think we'll see perhaps a planet polio-free?
So before we segue to polio, let me link them by telling you one of the most positive stories in the Ebola response of the last 9 months is that, in late August, a very sick person on a plane from Liberia landed in Lagos and introduced Ebola into Nigeria. In the next 2 months, there was a lot of concern. Nigeria is the most populous country in sub-Saharan Africa. It's got, in some places, very weak health systems. In the end, Nigeria controlled its Ebola outbreak at 19 cases, about half of whom died, which was a case fatality similar to what we saw in the three other West African countries. And it's interesting to understand what enabled that response. What happened is the Nigerian government was able to take capabilities that they had been put in place for the polio response, which has been surging, if you will, and we're seeing some very promising results. So and a key component of the success in polio has been the formation of these emergency operation centers, where various different representatives, different groups, technical assistants, the Ministry of Health, the foreign technical providers, the UN agencies, all work on the same incident command, look at the same data, analyze and iterate on important, responses, and then getting real-time feedback. That bringing together has been critical to the success and coordination of the efforts. So one of the things that, because of what we learned in polio, one of the things we did at the Gates Foundation is that we have a emergency response program that's in my division that's normally not that big, but we made in early September an extraordinary extra contribution. Bill Melinda authorized another $50 million for the Ebola response. And one of the things we did is we said, and we announced that, and then we had thousands of people contact us to see if we could support their work. And they were all good people wanting to do good things. And we had a simple criteria. We said, if your request hasn't come to us through the incident command of the Emergency Operations Center in that country, we're not even going to open the file. Because, think about how distracted a stretched, small team of leaders in the country, healthcare will be if 1,000 people show up to help in an uncoordinated way. So we said, look, we're going to help use what influence we have through funding to drive coordination through these emergency operations centers to get everybody working off the same set of data and coordinating their response so that you don't lose, effectiveness to inefficiency, because in an outbreak like that, time is actually quite critical given the reproductive rates of the infection. So, so switching to polio, to answer your other question, what the polio assets in Nigeria really actually help prevent a much larger outbreak of Ebola if Ebola had taken off in Nigeria like it did in the 3 Mono River countries, we'd be in a very different place as a world today. And so it's worth thinking about
because
that
of the porous borders, the travel, the wealth of the country, the population.
The biggest population, one of the most mobile populations, not just in Africa, but in the world. Right. I spent a lot of time in Bangkok, and a lot of people in the market, there are Nigerians buying textiles and moving them around. I mean, it's a very highly entrepreneurial country that travels a lot. And so, had we had a major outbreak beyond those 19 cases in Nigeria, we would have a very different world today. And some of that response is, that's all, all that credit goes to, the public health leadership there. In fact, Faisal Schwab, who was the deputy incident commander of the polio emergency operations center in Abuja, basically got on the plane the night that case happened in Lagos, and for the next 2 months, he ran that emergency operations center in Lagos. So it was not only the information technology and other assets of the polio program, but actually the people. And CDC, WHO, UNICEF all redeployed people from polio to Ebola to help stop that outbreak. And the reason they could do that is that they were all in the midst of what we called the surge, or the final push for polio eradication in Nigeria. It has now been over 8 months since the last case of polio in Nigeria. Saturday will be 8 months since the last case of polio anywhere in the African continent. The last 2 cases of polio in Africa were in Somalia on August 11th, and they were the tail end of an outbreak that started from an exportation from Nigeria into Somalia in 2013. Big epidemic, mostly in the al-Shabaab-controlled areas where there was limited access to the vaccination teams. And that epidemic seems to have finally been wrapped up in August. But in July 24th was the last case in Nigeria. Nigeria was the only place in Africa that had never interrupted wild poliovirus transmission. Now, we have to go a year before we can say definitively that we think we've done it. But the models and the coverage rates suggest we may have finally succeeded. We've certainly never gone this far before. And that's been a combination of political leadership from the federal government, but mostly from the state governors in the 11 high-risk northern states, followed through to local level leadership, the introduction of emergency operations centers in Nigeria that began in 2012, getting the Nigerian public health officials in the same operating facility as the technical assistance provided by WHO, UNICEF, the CDC, the Gates Foundation, others. That coordination and a independent evaluation of the quality of the campaigns, the vaccination campaigns, and enough staff to actually competently execute and to continuously improve the performance. So we now think we have seen the recipe for what works. You know, the history of polio eradication is that in 1988, when the World Health Assembly set the goal for polio eradication, there were over 100 countries with polio transmission. By 2000, there were 5. By 2004, Egypt eradicated, and then we went almost a decade with the same 4 countries. And then in 2011, India, which many people thought was going to be the last place, given the birth cohort and the population density, et cetera, India had its last case in January of 2011. So we learned a lot of things in India's success that we applied in Nigeria. And now we're applying both of those learnings to the final place, which is Pakistan and the neighboring borders of Afghanistan. So today, this year, there's been 21 cases of polio in the world. 20 of them are in Pakistan, 1 case in Afghanistan. And a lot of these elements, the EOCs, the management, the independent monitoring, et cetera, lessons from Nigeria are now being applied in Pakistan. So, you know, I forget who it was who said never predict things, especially about the future.
Someone wise. Let me ask you a question about, let me go for a few minutes and talk about you. When did you decide that you wanted to go into medicine? What formulated that for you?
It must have been sometime in high school. Because when I went to college, I actually enrolled in a pre-med program. I was, in high school, I was very into science, and particularly chemistry and biology. And so in some ways, I kind of, somewhere, I don't know, there was no spark. I can't remember the spark, but I guess my parents encouraged me, and I liked science, and that's so I started. I almost didn't go to medical school, though. I did start off on that track in high school, though.
But after your residency, which you did in where? You did Michigan?
No. So I went to college and medical school at Creighton University in Omaha, Nebraska. And then I did my internal medicine residency at UCSF.
Right. So after you did that, you went to Thailand to work with refugees on the Cambodian borders, which would have been in the late 70s, around that period of time. What impact did that have upon you and your future? And what did you realize then about the world that you hadn't really realized before or thought about?
So if I understand where you're going with this line of questioning, there's a piece I should fill in for you.
Okay, fill it in.
So, you know, I left high school, went to college thinking I'll be a pre-med student, and I mostly took science and math courses my first couple of years of college. And then, partly because of a roommate I had who challenged me, I actually started taking some social science classes in political science and sociology, and actually got quite interested in sociology. So I came actually very close to not going to medical school and almost went to get a PhD in sociology. And I'd spent a summer, because I was kind of late in getting interested in sociology, so I wound up graduating high school with 2 majors in chemistry and sociology. And it was really chemistry and then sociology was kind of my college career. And I spent a summer actually at the University of Kansas with a mentor kind of really getting really into sociology. And I was thinking to do that. And then in the end, I decided to go to medical school and actually drove down to Kansas to tell him that I was going to go to medical school and not go to sociology. And I expected him to be disappointed. And he said, he was an older and wiser guy, and he said, "That's okay, you'll be back." And that's important, because then what happened is I went to medical school and learned, you know, in those days, medical school, at least my medical school, was much more of a biomedically focused thing than I think many medical schools are today. And that change is a good thing. And so when I came out of medical school and then did my internal medicine residency, I was kind of, you know, back in the tunnel vision of medical science. And so when I went to work on the Thai-Cambodian border, first as a medical student for a couple of months, and then actually as a resident, I convinced the University of California to let me go for 3 months on my elective time to work back in the refugee camp. And then when I finished my residency, I went and worked for 2 years on the Thai-Cambodian border. And that sort of background interest in social science and the broader context in which medical science actually happens in people's lives kind of came just full force to me. That working in what was at the time the largest Cambodian refugee camp in Thailand, you just see the consequence of conflict, of psychological trauma from an immediately post-genocidal population, of poverty, just of the mean-spirited policy that says that this is a temporary camp, so you can't build with anything other than bamboo and thatch, and therefore you can't have any running water, and you can see the marvels of what you can do with a little bit of medicine, even in a place like that. But at the same time, if you step back at all, you see the context that has largely determined that you've got 350 kids in the hospital every day from diseases that are largely preventable. And that's really kind of where I started making my shift to public health, and really went to the University of Washington to do a public health degree, and really have been doing global health or international public health primarily since then. And for me, that was kind of bringing together that early interest in the social and political sciences with the medical science that I started off on sometime in high school.
And as Michelle mentioned, you were president for many years at CEO of PATH, a Seattle-based international NGO, basically. What are you most proud of creating there? And what did you bring from that experience to Gates? You went from there directly to Gates. What's your legacy there?
So it depends on how, it's always interesting to answer that question when you're the CEO, right? Because I used to say when I was the CEO of PATH, as a large nonprofit with 1,300 staff and a budget of $325 million a year, most of which was restricted grants and contracts, I used to, jokingly, but not actually kind of accurately describe my job as a third of the time I did fundraising, a third of my time I did cheerleading, and another third of my time I solved really thorny HR problems that no one else wanted to deal with. Right. And there were a few other things in between the cracks. So that, all the great project work of PATH was done by the great people we hired. And so, and the partnerships we formed, because, much of PATH's biggest, achievements were, and I think this is true for most global health and development organizations, that very few things actually get done by one person or organization these days. It's a collaborative effort, and we see that in Ebola and polio and a variety of things. I did have a bit more role in some of the partnership formations, but I think I think the real answer is what I think my legacy was helping create an organization that enabled talented people to come in and do great things. And to some extent, that's the CEO's job description, right? It's not to actually get in the weeds and do this or that. I think the project that, was probably iconic in a way, it started a year after I got there and took 10 years, was that we formed a very interesting partnership between PATH and the World Health Organization, 30 or 35 other people and institutions along the way, to develop a specific affordable vaccine for African meningitis. It was a complete failure of the market. We put together a very innovative public-private partnership with support from a $70 million grant from the Gates Foundation. And in 9 years, took us 9 years to develop the vaccine. We developed a vaccine for the 25 countries of the meningitis belt that, since it was introduced in 2010, in the countries where the coverage, it's now been introduced in all the meningitis belt countries, and in some of those hyper-endemic countries in the Sahel, they can't even find that strain of bacteria anymore. And this was an outbreak that used to kill and maim people. It was one of the awful things of regular seasonal annual outbreak, sometimes big, sometimes small, of meningitis that would strike young kids and young adults up to the age of 30, and it didn't kill them. It killed about 10% of them, and caused another 10% to be deaf, and left many others with neurologic capabilities. And this vaccine, which we developed at 40 cents a dose, seems to have actually eliminated it as a public health problem. It's not the kind of thing you can actually eradicate, but you can get rid of the cases and stop the suffering. That was, in some ways, I was part of helping put that partnership together. There are many, many people who actually did the day-to-day work. But that, creating an organization that could do that kind of flexible work, working with industry, working with the UN system, working with some of the poorest countries in the world, to develop and then actually deploy at scale a global public good to actually eliminate one of the region's biggest public health problems. I think that's the project that resonates. There are many, many others like that. Some of them actually probably even save more lives. But in terms of bringing together the pieces of the global health architecture to serve the poorest of the poor in an affordable way is kind of, and to the extent that PATH can do that on many things, that's hopefully my legacy.
When you're being Seattle-based and an NGO, are one's eyes always focused on Gates Foundation as a possibility because of the power, the authority, the prominence, everything, or no? Or yours? No,
I mean, it's interesting. I started working with the Gates Foundation when I was still living in Bangkok in 1998. I was the recipient of probably one of the first 10 grants in global health that the foundation made to do some clinical work on microbicides that Michelle was talking about. So I've known the Gates Foundation from a very early day. And when I joined PATH in 2000, and PATH, has been around since the 70s. It was there a long time before the Gates Foundation. They just happened to be in the same neighborhood, which is a good thing.
Nice neighborhood.
But when I joined PATH as CEO in 2000, the Gates Foundation had 5 people in their global health program. I had them all on my speed dial. They took one column. And PATH grew a lot, but the Gates Foundation grew even more. I joked with Bill Melinda that we kind of grew up together in Seattle. And actually, for most of the time I was at PATH, it never occurred to me to think about working at the Gates Foundation, because that was just one more arm's length from the real work in the field, right, to be a funder of that. And so, I'd been at PATH about 12 years when Bill Melinda and Jeff Rakes, our former CEO, talked to me about coming to the foundation, partly because they were wanting to be a bit more intentional about some of the delivery at scale types of challenges, as they were learning that developing new technologies could happen and could be incented. You could get these public-private partnerships together, but that we were increasingly hitting bottlenecks in the introduction and delivery of those technologies. So, it was really a conversation about this being an exciting new challenge for me personally, for the foundation, in terms of some of its directions in its global health and development work. But I think and I knew the foundation quite well. Obviously, that we'd raised over $1 billion of grant support from them while I was at PATH. So we had 45 active grants the day I switched over. So we knew the foundation pretty well. But I was still surprised when I moved 10 blocks and started working for the foundation about the potential of catalytic philanthropy, especially given the size of the resources of the Gates Foundation, which are almost about $5 billion a year of philanthropic capital. The ability, when it works well, to be a neutral convener between other donors, including rich country donors, bilateral donors, the UN system, the companies, both in multinationals as well as in emerging markets, the civil society organizations, academia. Because we kind of work with all of them, we're in a unique position to create some interesting partnerships. And I don't think we get that right every time, but when we do, it's pretty powerful how you can harness a lot of great energy and resources for to reduce some of the biggest inequities in the world.
And when you don't get it right, what are the failures of not getting it right? When you look and you analyze why you're not getting it right, what are the lessons learned?
My favorite simplistic answer to that is a recent quote I heard from Warren Buffett, who, of course, is a trustee of the Gates Foundation. Warren, I think it was in his most recent annual letter, said that the things that, cause organizations to stumble are the ABCs: arrogance, bureaucracy, and complacency. And when we don't get it right, you can usually find some mixture of those three things. When we think we know more than we do, and a lot of that involves listening to partners, particularly people in country. Our bureaucracy, we grew fast. And any fast-growing entrepreneurial organization, I used to say this when I was CEO at PATH, because we grew fast at PATH when I was there too. And if your job is, there's sort of a natural centrifugal force to entrepreneurship. If you hire really bright people and you put them on hard problems, they just go, and they'll go in different directions, actually. And so you do have to manage that centrifugal force of hard-driving, mission-driven entrepreneurship with an intentionality around shared culture, values, goals. And you can go overboard if you overmanage entrepreneurs. They don't stick around for very long. And so, getting that balance right. So what I've seen in many organizations, at PATH, the Gates Foundation, others, is that when you grow fast in a mission-driven entrepreneurial organization, you get silos. And then part of the responsibility of senior management and executive leadership is to break down those silos, to get the collaborations going, to don't miss the opportunity. I was just with a couple of important partners in the last couple of weeks, and I realized they were having 3 different conversations with 3 different groups at the foundation and hearing different things. Mm-hmm. And that confused them, and it was just inefficient. So getting our bureaucracy right so that we're not overly rigid and process-driven and more focused on the results is an important piece. And we're not unique in that. I mean, that's what most growing organizations deal with. And then complacency, failing to ask the tough questions.
And what are those tough questions that sometimes you may fail to ask?
There's a lot of, and I think it's a problem for us, it's a problem, I think, for the field, is that, and it kind of goes back to the early days of my career when I was in Southeast Asia. We would often do, in the 90s, we would do little projects, and good projects. And the last paragraph of the report was always the same. Said, we're really happy with the results of this pilot project, and if anyone ever got serious about putting money and political will behind this, we could scale it up, make a big impact. And so we were so used to being so resource constrained that we dimensioned our ambitions to what was feasible, what money we could raise from USAID or the UN, and those budgets were half or less than half of what they are today in those organizations. So what's happened in the last decade and a half in global health and development is that there is more political attention. The G7 talks about health. They didn't used to do that. There's more. The UN General Assembly has a special session on AIDS, on Ebola. The World Health Assembly. There's more political attention. There's more resources, both international from bilateral governments. The U.S. government, most of the G7 governments have significantly increased their development assistance for health and development. And there are rising budgets in domestic resources in countries. Many of these countries have found new mineral wealth. We had last week President Kikwete from Tanzania was in Seattle. He was talking about they just found new gas reserves and how they're going to harness those for social sector improvements. We have to, those of us who've been in global development for a while have to think bigger than we were taught to think when we started in this field. And that's where I think there's a very important role for the new entrants, if you will, the students, the fellows. We've also crowded in a lot of people to global health and development who previously were, in business schools or other places where they might not have been interested. So I think we have to not ask the tough question. If I go back to my meningitis vaccine example, back in 2001, when we sat around and said, well, maybe we could develop a vaccine that was less than $1 and could actually eliminate this disease, that wasn't a question we would have asked 5 years earlier. The fact that the Gates Foundation was willing to make a 10-year, $70 million investment, today we've seen that happen a number of times, but in 2001, it was game-changing in terms of not just it allowed us to get out of a complacent view of how do we control these things with the tools we have or the science we have, and actually think bigger. And I think that's a challenge to the entire field. We try to challenge ourselves with that as well, because there's so much received knowledge about what's possible and what's not in global development.
Roll it out more about what you really mean about thinking bigger, so that the students here really understand what will be expected of them. So talk about that a little more.
Let's go back to where you started with Ebola, right? So Ebola was a wake-up call. We shouldn't miss this moment, right? We've got, the UN Secretary General doing a review of how do we be better prepared. We have the G7 as on their agenda for June. The World Health Assembly has charged the Director General to come back with a report of what worked and didn't work within what were the failings of the WHO and how could they be addressed. So we shouldn't miss this moment to set the world's sights bigger for outbreak preparedness. Because if we don't, 9 months from now, people are going to forget about Ebola. It's already fallen off the news cycle. It's actually still, we're not at zero yet, particularly in southern Guinea. So, but because it's no longer,
news.
Most Americans have already forgotten about Ebola. So before we all forget about Ebola, let's take that wake-up call and think about. So what would it look like to have a global outbreak alert and response capability? What would we have to do, both in terms of organizing surveillance, right? It's interesting, in places where Ebola has happened previously multiple times, there is actually some surveillance capability, even in some of those really poor countries like Eastern Congo. But there was no surveillance in West Africa. We weren't looking, right? So how would you, and we don't know where the next emergent infection will be. So we're going to have some, we should have some outbreak alert and response system in place everywhere. What's that going to take in terms of the organization of the global architecture? A lot of what didn't work well was that there was confusion between levels of some of these bureaucracies, between countries and regions and headquarters. How do we get the right incident command for response? How do we know when we have a problem? Through event-based surveillance, and there's a set of criteria that are being evolved through the global health security agenda that the US CDC and others have been articulating. To do that is going to require significant resources. This goes back to, Bill's TED Talk was, look, we don't have to spend as much money as we spend on the military, but, something more than we're spending, and a significant more, to be prepared for the thing that might actually kill 10 million people. That's going to take getting out of a complacent view, and it's also going to require innovation, both in organizational structures and political structures and in technological structures. What are the diagnostics that would allow us to more rapidly detect things like Ebola, other filovirus emergences, et cetera? So there's I think we should collect, you could have a long list with the Reserve Corps of people. There's a complex R&D agenda. We got lucky that Ebola was sort of somewhat strangely listed on the list of key bioterrorism targets back in 2001. That's why there was some R&D being funded by the Defense Department, even though Ebola is not exactly what you would think about as an ideal bioterrorist target weapon. So, where are the blind spots in surveillance and research and development? These are things where the market's not going to work, right? Because they're black swans, right? They're big, unpredictable events. They're not predictable demand forecasts that you could put a business plan against. So we're going to have to, as a global community, get out of a complacent view of being comfortable with blind spots in our surveillance for outbreaks, incapacity, explode the myth that there's somewhere a big core of health workers that we can deploy tomorrow, because there isn't. Build one. So I think Ebola actually could be a rallying point to actually break out of some of the complacency that put us at the risk that we had in being so unprepared when a virus that had been around since 1976 emerged in a place we hadn't seen it before.
Want to go to questions? Yeah. Let's open it.
Sure. Sure. So we're very aware of the rising disease burden of non-communicable diseases. In fact, we support a lot of the data aggregation that is actually showing those trends. So we have a major grant with the Institute for Health Metrics and Evaluation at the University of Washington, a variety of other disease burden and the disease control priorities work, network, et cetera. One of the myths I like to challenge about the Gates Foundation is a lot of people assume that if we don't fund it, we don't think it's important. There's a whole bunch of things that we know are important that we don't currently fund, because even though we have a very large budget, we have to stay focused. And in fact, we're in probably, we're not in too many things, but we're in many things. And so adding additional strategies at a time when our, the budget's roughly flat, and we have rising needs in some areas that we're already working, like polio and the end game and nutrition, et cetera. We don't anticipate expanding into a lot of new areas, even though we understand that there is, especially as we make continued progress in maternal child reproductive health and reduce communicable diseases, certainly the proportionate share and the absolute disease burden of non-communicable diseases is going up. I think the answer is that it'll probably be when, not if, we'll get involved in NCDs, but we're not going to add additional areas of focus. Whether it's NCDs, mental health, injury prevention, these are all important and increasing causes of disease burden in the world. But we're going to remain focused on finishing the job in the preventable maternal and child mortality for the time being. As we succeed there, we'll obviously free up resources that could go to some of these others. One of the ways that we make decisions about where to go is looking at disease burden, looking at the trajectory of disease burden, and then understanding what other people are doing and not doing. So when we get to, and the thing that we're doing now more than we did a few years ago is investing in primary healthcare systems in some of the poorest countries. That will build the platform for NCD approaches, even if we're not specifically supporting those. When we do more in NCDs, we'll probably do more in the delivery side, because the research and development is actually pretty well supported by the existing R&D of multinational companies. Take diabetes, right? The multinational pharmaceutical industry spends $5 billion a year in diabetes R&D, which is our budget. So we're not going to have to invest in finding the next diabetes drug in the way that we invest in, malaria vaccines, where we fund a large proportion. We may have to work with those companies on adapting new innovations that they develop for rich countries into forms that are more deliverable. The target product profiles may need to be adapted for poor countries. But that, I think, will come in the future. For now, we're not investing in NCDs, other than there's always an exception, right? We do a lot of work in cervical cancer prevention, and a couple of other non-communicable, they're actually communicable chronic diseases. But both in vaccine, development of HPV vaccines, as well as diagnostic and treatment for older women with HPV-related disease. So we have a few exceptions, but we're not working on the major ones: diabetes, hypertension, pulmonary disease, et cetera, coronary artery disease, et cetera, yet. But I think it's really probably a matter of when, not if, but it's also not right now because we've got a lot to do with the existing major causes of maternal and child mortality.
Go there.
Hi. How do you think through funding nonprofits? Sure, I'm Ryan Pierce from bioengineering. How do you think through funding nonprofits versus for-profits, and then in the for-profit category, large organizations versus startups?
How do I put it? I think we're increasingly agnostic about, it's really a matter of who's best positioned to solve the problem. And usually it's a combination of those. So I think in the beginning, the foundation's 15 years old. I think at the beginning we primarily funded nonprofits because we were just growing as a foundation. If you look at in the last 5-6 years, we've begun to use a much broader set of tools, program-related investments that complement. Still, we make more grants than anything else, but we also are doing volume guarantees with companies, both emerging market and multinational companies. We've done equity investments in a variety of biotechnology companies, and we're looking at some of the ag technologies as well. And we've done concessional loan financing for a variety of both governments and companies. So we're beginning to work with, I think, if you looked at the trajectory, we have a much more diverse set of partners now than we did at the beginning. As we've grown and become more experienced as a philanthropy and understood all of the tools that a catalytic philanthropy can use, especially one that has a very large balance sheet that can do things like volume guarantees that a small nonprofit or a smaller foundation couldn't do. Volume guarantees have been interesting because we can, by taking the uncertainty out of the demand curve for companies, we often can have them greatly reduce their pricing because they can take the risk out of it. So we announced a couple of years ago, for instance, that we did a volume guarantee with the 2 major companies that produce subdermal contraceptive implants. And as a consequence of those volume guarantees, where all we did was, based on careful analysis, and we don't take irresponsible risks, we thought we understood the markets in developing countries better than they did. We guaranteed volume, and they were able to drop their prices from $18 a dose down to $8.50 a dose. We didn't actually have to spend any money. Right? We just had to guarantee the demand, and then they could adjust their production, optimize their production for a predictable volume. So there's a set of interesting tools that we can use, and we've done that with emerging market companies as well as multinationals to help influence the market dynamics in a way that allows them to drop their prices for poorer countries because they don't spend a lot of time understanding those markets, and we do.